Hello and welcome to today's lecture on nails and nail disorders, presented by myself, Dr. Eloise James, based in Melbourne, Australia, and Dr. Ian Coulson, a consultant dermatologist from Burnley, UK. In today's lecture, we'll be going through a brief look at normal nail anatomy, clinical examination and common nail signs, nail infections and trauma and what these can look like, drugs and how they can impact the nails, inflammatory disorders of the nail unit, common skin diseases and their nail signs, a few systemic diseases and their nail signs, and then a look at nail tumours and pigmentation, and a look at how benign versus cancerous changes can be distinguished and how to be aware of them. Now, just take a second to consider the functions of the nail. How do your nails help you in your everyday life? The main functions of the nail from an evolutionary perspective are to protect the digits from trauma, and they aid in fine tactile sensation and our dexterity, for example our ability to use our hands effectively in movements such as picking up a coin. As shown in the image on the right, we call the entire area the nail unit, which is formed from the nail plate, which is made of hard keratin, which is attached to the phalanx by the nail bed. The nail bed is referring to the nail matrix, which is a sterile matrix that does not contribute to growth, but allows growing cells from the germinal matrix to grow over the top. The germinal matrix contains dividing cells which eventually keratinize to become the nail plate. Continuously dividing cells push the nail plate over the smooth surface of the sterile matrix to form the plate. Also, not labelled in this photo, but we have the hyponychium and the eponychium, which is also known as the cuticle. This is a thin layer of stratum corneum. The lunula, which is the half moon we can see when we look at our nails, is the visible germinal matrix. Therefore, any issues with the nails, disorders or abnormalities arise from problems with the nail plate, the nail matrix, or the nail bed, or indeed the skin surrounding the nails, known as the nail folds. Nails are a key and unmissable part of the skin examination, and many diseases have nail changes which can be key to diagnosing diseases or systemic conditions, and can also sometimes give us further information about prognosis. As well as in dermatological exams, you'll be expected to examine the nails in cardiology, respiratory, gastroenterology and rheumatology exams to identify nail signs in their respective conditions. So it's important to not forget this. Things to look out for when examining the nails are nail length and texture, any signs of slowed or increased growth, any grooves or ridges in the nail. You can look at the colour of the nail, whether it's white, yellow, darker than usual, and are there any changes to pigmentation. Examine from the side and ask the patient to place the fingers together to examine for clubbing or cordylicia, which is spoon-shaped nails. You must then examine the skin surrounding the nails for any diagnostic clues for the nail changes that may be present. Colour changes. In this slide we'll discuss terms used for colour changes to the nail and what these can indicate. In general, when describing colour change, you must highlight whether or not it is full or partial. Leukonychia, or white nails, is a term used to describe the whitening of the nails. A way of remembering is thinking that leukocytes are white blood cells, and therefore leukonychia is whitening of the nails. This is the most common form of colour change in the nails, although it is a non-specific finding and has many different causes. It is either true leukonychia due to abnormal keratinization, or apparent leukonychia due to another disease. Apparent leukonychia disappears when pressure is applied to the nail. True leukonychia can be a result of trauma, chemotherapy, low calcium, low zinc, or heavy metal poisoning, all problems where the keratin is disrupted. Partial leukonychia can be punctate, which is the most common form, longitudinal or striate, as shown in the images. The most common causes of leukonychia are acquired causes, such as trauma to the nail, for example nail biting or having manicures, and systemic diseases, which include liver disease, chronic kidney disease, heart failure, GI diseases such as Crohn's and colitis, diabetes, iron and zinc deficiencies, and hypothyroidism. Iatrogenic causes include chemotherapy, as previously discussed, heavy metal poisoning, for example lead, arsenic, and sulfonamide antibiotics. Another nail change, which isn't actually a colour change, but does add a yellowish tinge to the nail, is onychomycosis. This describes fungal infections of the nail, which adds a yellowish tinge, and this can be very obvious or indeed very subtle. This may require further investigation with nail clippings to aid in our diagnosis. Another nail change which may be observed is green nails, which is a sign of subungual pseudomonas. Yellow nails, known as yellow nail syndrome, which is not pictured, but this can occur when nails appear yellow and raised and can be due to issues with lymphatic drainage from the hands, for example in cardiac or pulmonary diseases. Onycholysis, another term used to describe lifting of the distal nail plate, which is also not a colour change in itself, but appears as a pseudo-colour change. The lifting of the plate adds a yellow or sometimes a white hue to the nail, due to the lifting from the nail bed. This is another non-specific finding, however, can be caused by trauma, dermatological diseases such as eczema and psoriasis, and systemic diseases such as thyroid problems, drug reactions, most commonly from tetracycline antibiotics, and from fungal nail infections. Pigmentation changes should also be identified and examined promptly for any sign of changes suggestive of malignancy or any suspicious features, which we will discuss later in the talk. Changes in pigmentation can represent malignancy, benign lesions, and also subungual hemorrhage. Here are some more images of the colour changes discussed on the previous slide. In the first image, we can see a fungal nail infection, which, as you can appreciate, is fairly similar in appearance to onycholysis. The clear line on the second image, where the nail is lifted, is a clue to this. The third and fourth images on the right are indicative of a subungual pseudomonas infection, a green nail. Now we will discuss shape and texture changes. Looking at the shape of the nail from the front and the sides is key to examination to identify any subtle changes suggestive of disease. Koilonychia, as pictured in the first image, is the spoon-shaped nail, which can occasionally be a normal sign, but is also associated classically with iron deficiency anemia, diabetes, states of low albumin, connective tissue diseases, exposure to solvents, and potentially treatment with acitretin, a dermatological drug commonly used in conditions such as acne. The second image shows pitting of the nails and the nail plate, which is shown, which describes subtle or obvious changes to the texture of the nail, and this can be a sign of many different dermatological diseases affecting the nail plate, for example eczema and psoriasis. We also can find ridging of the nails, described as either transverse or longitudinal, which can be a sign of dermatological conditions such as eczema, psoriasis, and lichen planus, or of fungal nail infections, Darrier disease, paronychia, and can also be congenital, and can be a sign of any underlying tumours. Roughness, or trachonychia, is also an important sign to note. Grooves in the nail can be due to trauma, subungual hematomas, and longitudinal grooves are classically due to cysts or warts underlying the nail plate. And then we find clubbing, which you undoubtedly will have heard about in other specialties, such as respiratory and cardiology. It means the loss of the normal angle in between the fingernails when placed face to face with the nail opposite. This can also be a normal finding, but is also a non-specific finding of underlying systemic disease. For example, in cardiology, this can be a result of heart disease, heart failure, and in respiratory, this can be associated with lung cancer, pneumonia, interstitial lung disease, cystic fibrosis, and sarcoidosis. And in gastroenterology, this can be due to malabsorptive states such as Crohn's or colitis, amongst many other things it can be associated with. Next, we will discuss infections. Term paronychia. Paronychia can describe acute or chronic nail inflammation or infection. Acute paronychia is present for less than 6 weeks, and if it's longer than 6 weeks, then we call it chronic. It is also sometimes called Whitlow. This condition is more common in patients with trauma, such as nail biting, patients who get manicures, infants who suck their thumbs, and also people who are taking oral retinoid treatments. It can also be associated with systemic chemotherapy, which termed chemotherapy-associated paronychia. Chronic cases are often due to dermatitis of the nail fold in conditions such as eczema. Acute cases of infection are most commonly related to Staph aureus, as well as Strep pyogenes and Pseudomonas. It can also be as a result of viral infections such as herpes simplex, which we call herpetic Whitlow. Chronic cases, such as those who suffer from dermatitis or eczema, and those who have occupations in farming, bartending, and cleaning, as their hands tend to be wet for prolonged periods, tend to be affected by Candida and Pseudomonas. Paronychia is primarily a clinical diagnosis. However, we can take swabs and clippings to be sent for cultures and gram staining if there is diagnostic uncertainty. Complications associated with paronychia are distortion of the nail plate leading to dystrophic nails, discoloration of the nail plate, as we have seen with the green nails associated with Pseudomonas, and brittle nails. Patients with underlying conditions such as diabetes may develop cellulitis of the nail and the nail folds, so thorough clinical examination of the surrounding area is required. Management involves supportive care with warm water soaks several times a day, as well as topical antiseptic agents. Chronic cases require management of the underlying condition that is predisposing the patient to paronychia. For example, if the patient suffers with eczema, they may require topical steroids around the skin folds, and a more intense emollient regime, for example. Some severe cases may require oral antibiotics or oral antifungal treatment. Here are some images of paronychia. The first image is likely a bacterial paronychia with the classic golden hue of Staph aureus, as you will recognize from previous lectures. Image 2 is showing the toenail of an athlete, as well as an ingrown toenail, which can increase the risk of paronychia. And on the far right shows an image of herpetic Whitlow in a patient on chemotherapy. Periungual warts are warts caused by the human papillomaviruses. Like all warts, they are more likely in children and young adults, and more common in patients with eczema and those who work with water and wet hands, for example, cleaners, farmers, and people who wash dishes in restaurants. It is also more likely in patients on immune suppression, for example, patients with transplants, or on immune suppression for systemic diseases. On examination, they appear as in the photos, with hyperkeratosis of the subungual region, with a cauliflower-like appearance, which we call packeting. And this can be visualized at the end of the nail. To differentiate viral warts from other potentially malignant processes, we can look for this packeting and also the telltale sign of small black or red dots, which are tiny blood vessels, as you can see in the second photo. ungual warts can be difficult to manage and can cause patients a lot of psychological and social distress, so it's important in the first instance to be very empathetic. Management includes conservative measures and education regarding hygiene practices to prevent spreading in a domestic, school and work setting. For example, hand washing, wearing gloves at work, and avoiding sharing nail clippers and towels. Topical treatments, such as salicylic acid, are used, as well as cryotherapy, which freezes the wart with liquid nitrogen, which has a 50 to 70% success rate. Due to how difficult they can be to treat, we have other treatments available, such as immune modulator creams, bleomycin injections, pulsed laser dyes, and laser evaporation. However, these are not widely used in the NHS. Another infection of the nail is onychomycosis, which is a fungal nail infection and can cause yellowing of the nails, as well as distal nail plate damage, shown in the photo on the right-hand side. In this slide, we will discuss nail trauma. Nail trauma is very common and is more common in those on anticoagulation and those with bleeding disorders. When taking a history, it's important to identify any injury, for example, from prolonged downhill walking, such as hiking, or those related to acute injuries. Acute injuries with higher force are more likely to cause hemorrhage with subsequent hematoma. It's important to know that hemorrhage underneath the nail can also be due to lesions such as squamous cell carcinoma or melanoma causing local bleeding. However, this is rare. Chronic injury, such as those wearing tight footwear or with repetitive microtrauma, for example in athletes and dancers, is more likely to be a subtler change. The hemorrhage can cause discoloration of the nail, which may be reddish, brown, purple or black. It is usually a clinical diagnosis, unless there are any suspicious features suggesting an underlying bony fracture or suggesting a malignant process. So features suggesting underlying bony fracture may be pain, which is not in keeping with the injury, or any phalangeal swelling, which would warrant an X-ray. When identifying if there is any sign of pigmentation changes suggestive of malignancy, the key to differentiate a subungual hemorrhage from a potential melanocytic change is that a subungual hemorrhage will grow out with normal nail growing proximally to the coloured area of the nail over a short period of time. So it's important to keep monitoring this when trying to distinguish the two. Next, we will discuss habit tick deformity, which is a form of psychodermatosis, a condition where patients pick the proximal nail folds, causing damage and local trauma, as well as hyperkeratosis of the nail fold, which in severe cases can cause permanent damage to the skin. This group of psychodermatoses is described as onychotillomania, which means habitual self-imposed trauma involving the fingernails or toes, which translates to nail pull madness. This can be primary or secondary to another psychological condition, such as OCD, anxiety, and depression, and often may come alongside things such as trichotillomania, hair pulling, or onychophagia, nail biting. Clinically, it would appear as washboard nails as shown in the photographs. This represents damage in the nail fold and hyperkeratosis of the proximal nail fold, and often affects the thumb and is asymmetrical. Complications include loss of the cuticle, superimposed infection with bacteria, viral or fungal, permanent nail dystrophy, and worsening of the underlying psychological condition. It is primarily a clinical diagnosis and may involve a mental state examination or assessment to help diagnose and guide management. Management is conservative. However, we can use physical measures such as bandages, adhesive glue on the nail fold, and dressings to wrap around the fingers, which may be helpful. It's important in the first instance to educate and validate the patient's concerns and suggest potential management techniques such as anxiety management and replacement behaviours, which can be encouraged, such as stress balls. It is important whether or not to consider a referral for psychotherapy or psychological assessment if there is severe conditions suspected underlying. Now we discuss drug-induced nail diseases, which can present in many different ways. In general, this is a rare phenomenon, however, is more likely in the elderly and those with polypharmacy. Nail drug reactions are associated with a wide range of medications. For example, many types of antibiotic, many types of chemotherapy, oral retinoid treatments, ACE inhibitors, antimalarial drugs, non-steroidal anti-inflammatory medications, anticoagulants and antiplatelets, which can cause splinter hemorrhages, amongst many other different drugs. In general, it is a clinical diagnosis. However, in diagnostic uncertainty, we can consider scrapings, clippings, or biopsy. Treatment is conservative. However, sometimes there may be concurrent paronychia or infection, which may be treated, as well as thinking of things like water immersions and moisturizer application. If possible or appropriate, we can consider cessating the causative medication. Next, we will discuss inflammatory conditions affecting the nails. Inflammatory conditions affecting the nails can present solely on the nails or nail beds without any skin involvement. Examples of inflammatory skin diseases that can have nail involvement are psoriasis, lichen planus, and eczema. As mentioned previously, it's a key element of any skin examination to examine the nails to identify if there is any nail involvement from the underlying skin disease. This is very important as nails can be the first presentation of a skin disease, for example psoriasis, and can also denote prognosis or risk factors for disease severity. In some conditions, destruction of the nail unit can be irreversible, such as in lichen planus, so it's important for prompt diagnosis and treatment. Nail lichen planus. To recap, lichen planus is a T-cell mediated autoimmune disorder where autoinflammatory cells attack proteins in the skin and mucosal keratinocytes. In the skin, a classical presentation would show as papules and plaques, with shiny tops with fine white lines along the top, known as Wickham striae, as shown in the first image. There are many variants of lichen planus, which are covered in other DermNet modules to refresh your memory. It is a fairly under-researched disease, although we do know there are some risk or contributory factors, such as genetic elements, psychological or emotional stress, trauma and the Koebner phenomenon, where the appearance of lichen planus is identified in skin that has been previously damaged, previous infection with herpes zoster, systemic hepatitis C, contact allergies, and treatment with drugs related to gold, quinine, and quinidine. Nail lichen planus can affect one or more nails. When inflammatory conditions affect all nails, we call this 20-nail dystrophy. Nail lichen planus can present alone, without any lichen planus on the rest of the skin, or it can present alongside the skin disease. It is very important to identify any nail changes in lichen planus, as they can be irreversible and cause irreversible loss of the nail plate, unlike lichen planus of the skin, which is often reversible. Clinical examination may show thinning of the nail plate with roughness and ridging, onycholysis, lifting of the nail plate, as described earlier. This can then cause complete loss of the nail plate, as shown in the photo, where the nail scarred so severely that it's actually stopped growing. Cuticle destruction can cause scarring and form what we call a pterigum, as shown in the third and fourth photos. Management for nail lichen planus involves topical treatment with either steroids or vitamin D analogues, and in very severe cases, oral steroids may be considered. And in rare cases, with specialist input, we may use oral immune modulators. To recap, psoriasis is an autoinflammatory condition characterized by epidermal hyperproliferation and inflammation. It can affect many different parts of the body, including the skin, nails, scalp, and joints, known as psoriatic arthritis. Nail changes in psoriasis can be associated with skin psoriasis, psoriatic arthritis, or can present alone in around 5% of the population. 90% of patients with chronic plaque psoriasis will have nail involvement at some point in their lives. Nail involvement in psoriasis has been associated with increased severity and duration of skin disease, and is associated with increased risk of psoriatic arthritis. Nail psoriasis can affect the nail bed, nail matrix, hyponychium or cuticles, or the proximal nail folds. Nail psoriasis is often intermittent and comes and goes with no clear pattern. A patient may complain of pain around the fingers and toes, altered fine touch sensation, and difficulty with fine manipulation, for example, shoelaces or buttons. The clinical features of nail psoriasis are pitting of the nails, onycholysis and nucleonychia, ridging or splitting of the nails, transverse or horizontal, which is known as onychorexis and bow lines, and nail crumbing as a more severe change. Oil drop sign and salmon patches are also seen, as well as subungual hyperkeratosis due to hyperproliferation of the underlying skin. Occasionally, there are splinter hemorrhages in the distal third of the nail plate. It's usually a clinical diagnosis within the context of cutaneous or joint disease, although if there is concern of infection, clippings may be taken. If there is no other sign of psoriasis, and there is diagnostic uncertainty for the patient, a biopsy may be taken, although this is rare as it can cause permanent nail deformity. Complications include paronychia and onychomycosis, and infection with bacteria and other viral infections. Management is multifactorial. In the first instance, general measures such as minimalising nail trauma and keeping nails short is recommended. If there is secondary nail infection, then treating this, usually for a minimum of 3 months. Topical treatments are very similar to treatment for cutaneous psoriasis, involving topical steroids, vitamin D analogues, and topical calcineurin inhibitors. Systemic treatments will also be used concurrently to treat cutaneous or psoriatic arthritis, which may include methotrexate, acitretin, and other biological treatments. These are some images of nail plate changes and clinical signs of psoriasis. The pitting is shown in the top left image, with small circular indentations and transverse ridges. The second image shows hyperproliferation underneath the nail plate, causing lifting of the nail plate. The third image shows severe nail crumbing. The bottom left shows inflammation around the proximal nail fold and surrounding psoriasis on the rest of the hand. And the bottom right image shows lifting of the nail plate, onycholysis, and a small area of a salmon patch, suggesting nail bed involvement underneath. To recap, eczema or dermatitis. This is an image showing periungual eczema changes and acrylic nails. Now we will touch on systemic conditions affecting the nails. Many systemic conditions can also have nail signs, many of which are non-specific. The examples of systemic conditions we'll cover in today's session will be a select few. These will be bacterial endocarditis, lupus, dermatomyositis, and diarrhea disease. These are only a small number, and there are many more conditions that affect the nails. Bacterial endocarditis. Bacterial endocarditis is an infection of the endocardial lining of the heart or the heart valves, typically involving gram-positive staph or strep, causing systemic infection with classical clinical signs. We are taught to look for hand changes. However, in reality, these are fairly rare and often non-specific. To recap, these hand changes are Osler's nodes, which are painful raised lumps with a pale centre on hands or fingers, and Janeway lesions, which are non-tender, painless, hemorrhagic lesions on the palms or soles due to septic microemboli. Nail changes include splinter hemorrhages, which are suggested to be present in 15 to 33% of patients with bacterial endocarditis. They are still a non-specific finding and can occur in physiologically normal nails, and also can be common in patients on oral anticoagulants. Lupus is a group of diseases. Lupus is a group of autoinflammatory diseases which involves immune dysregulation and the activation of complement and the subsequent production of autoantibodies. Lupus can mean systemic lupus erythematosus, known as SLE, which affects the skin, joints, bones, vasculature, and cardiorespiratory symptoms. When present only on the skin, lupus is known as cutaneous erythematosus. There are known risk factors for lupus. These are some genetic factors, HLA-B8 and HLA-DR3 haplotypes, sunlight exposure, viral infections such as EBV, hormone dysregulation, smoking, and emotional or psychological distress. Cutaneous manifestations of lupus are classically a malar or butterfly rash of the face, a blistering rash which can resemble toxic epidermal necrolysis, mucosal erosions and ulcerations, photosensitivity rash, and non-scarring alopecia. Diagnosing SLE involves both clinical examination, serum testing, and potential biopsy. Diagnostic assessment can be very complex, and criteria has been suggested involving clinical and immunological criteria. Nail changes in lupus are more common in SLE than cutaneous erythematosus. The nail changes include cutaneous lesions surrounding the nail fold and the digits, prominent capillaries around the nail fold, lupus lesions around the nail bed causing paronychia, leading to ridging and splitting, discoloration due to vascular changes, pain and crumbling of the nail. It is also important to note that medications used in SLE can also cause nail changes, and many patients will be taking immune suppression and will therefore be at increased risk of fungal infections. Here are some images of the nail changes seen in lupus. The prominent capillaries around the nail fold is seen in the first image, due to small vessel vasculitis. Paronychia due to periungual lesions, causing ridging and grooves and onycholysis. And the third image shows a patient with lupus who's had a UV light manicure, and this can increase the risk of a flare in patients with lupus photosensitivity. To recap, dermatomyositis. You may be familiar with the condition from rheumatology or oncology lectures. It is an inflammatory myopathy with classical cutaneous features. It is strongly associated with underlying malignancy and is often considered a paraneoplastic condition. Any patient presenting with findings suggestive of dermatomyositis should be fully investigated for underlying malignancy. Other risk factors for dermatomyositis include specific medications, for example, hydroxyurea, penicillamine, amongst many others, as well as viral infections and occupational exposure to silica. Classical skin changes you may be familiar with are photosensitivity heliotrope rash on the face associated with eyelid swelling, shawl sign on the back and shoulders, and Gottron's papules on the elbows, knees and hands. Nail changes, which are shown on the next slide, are non-specific but can be a clue to support diagnosis. Generally, dermatomyositis doesn't affect the nail plate, only affects the nail folds, which differentiates this from eczema and psoriasis. Nail fold changes include erythema around the nail folds and prominent capillaries seen on dermoscopy. General management for nail changes is photoprotection and reduction of sun exposure. There is a potential use for topical steroids and calcineurin inhibitors, and monitoring for any changes suggestive of infection as a result of immune suppression. Management of the underlying systemic disease will improve nail fold changes, for example, systemic steroid treatment, hydroxychloroquine and IVIG, as well as steroid-sparing agents such as methotrexate. Here are some images of the nail changes in dermatomyositis. Nail fold changes can be fairly subtle and require in-depth clinical examination. There is often non-specific changes of paronychia, periungual erythema, and prominent capillaries. Diagnostic clues can be seen on the rest of the hands, such as in the image on the bottom right, which is showing Gottschalk's papules. Diarrhea disease. Diarrhea disease is an autosomal dominant condition that typically presents before the age of 20 years. It is considered to be an acantholytic disease, which means the loss of keratinocyte adhesions to one another via desmosomes, which results in scaly, greasy papules in the skin folds and in the seborrheic distribution. The seborrheic distribution refers to areas where there are seborrheic glands, such as on the face, scalp, ears, neck, chest, and back. There is a spectrum of severity in diarrhea disease, and some patients are asymptomatic, with findings only on deep inspection. Most patients will have nail findings. The lesions are typically coarse, firm, and skin-coloured, or yellow and brown. The nail signs are longitudinal red or white streaks on the nails, and deformities with V-shaped nicks at the free edge of the nail. General management of cutaneous features are avoidance of sun and good sun protection, moisturizers, and some patients may require topical or oral retinoids for severe disease, and management of any secondary infection. Now we will cover nail lesions, cysts, and tumours. Nails are a less common site for lesions like cysts, tumours, and malignant changes. However, this means they are easily missed on examination. Lesions can be benign or malignant, although many will require biopsy due to diagnostic uncertainty. Cancerous lesions that we will cover in this lecture will be squamous cell carcinoma, as well as malignant melanomas. The benign lesions we will cover will be glomus body tumours, periungual fibromas, and onychopapillomas. Glomus body tumours. Glomus body tumours are benign nodules that grow from the glomus body within the perivascular smooth muscle cells in the arterioles of the hands. The glomus body helps in vascular regulation of skin temperature and controls blood flow to the nail bed. Glomus body tumours are exquisitely painful, especially with temperature or pressure changes when the arterioles are dilating and contracting. They are more common in young adults. They present as small, solitary, painful lesions in or around the nail bed that are typically red or blue and around 1 centimetre. Classically, a linear blue lesion is a diagnostic clue to glomus body tumours. They will usually require a biopsy, and histology will show glomus cells surrounding small blood vessels. Treatment usually involves surgical excision. Periungual fibromas. Periungual fibromas are benign lesions typically found in young adults and adults of patients with tuberous sclerosis complex. A quick recap of tuberous sclerosis complex. It is a rare autosomal dominant condition characterized by hamartomas in many different organs. Hamartomas are benign cell hyperplasia native to the organ they are growing within. Tuberous sclerosis complex is also associated with developmental delay and epilepsy, and affects patients along a spectrum of severity. Cutaneous lesions that are characteristic are facial rashes as a result of angiofibromas, Sjogren's patches, and ash leaf marks or patches as shown in the first image. When tuberous sclerosis complex affects the nails, we call the lesions periungual fibromas. They are smooth, flesh-coloured lumps that arise along the nail fold, or subungual. They are more common on the feet than the hands, and can be accompanied by splinter hemorrhages and leukonychia. They can be difficult to treat, but are benign. If affecting quality of life or functional ability, surgical resection can be considered. Myxoid cysts. Cysts of the nail unit region are described as digital myxoid pseudocysts or cysts. They are now termed pseudocysts because they lack a capsule as in a true cyst. They are common and also termed a mucous cyst, a digital ganglion cyst, or digital synovial cyst. They are benign. There are two main forms: pseudocysts associated with osteoarthritis, from the synovial lining of the DIP and PIP joints. These are the most common. The second type is related to focal mucinosis, a condition characterized by increased deposits of mucins in the skin. Clinically, they appear as translucent and shiny surface lesions at the base of the nail, and you occasionally may be able to express clear or blood-stained fluid from the cyst. They can be painful or painless. It is primarily a clinical diagnosis. Management is difficult and there is a high recurrence rate. You can press firmly on the cyst to express, or use sterile needle aspiration. Cryotherapy is sometimes used, as well as steroids or sclerosant injections. Surgical removal can be considered in certain cases. However, there is a high recurrence rate. This is an image showing a longitudinal nail groove and guttering, which can be a sign of an underlying myxoid cyst. Onychopapilloma. Onychopapilloma are benign lesions of the nail matrix, which affect mostly one nail in isolation and rarely affects multiple nails. In very, very rare circumstances, they can have malignant potential. However, in general, they are benign. They are very rare and are mostly limited to adults in middle or older age. Clinically, they present as a longitudinal streak in a red nail, known as erythronychia. However, this can also be white or brown. Distal splitting of the tip of the nail or onycholysis may occur, as shown in the third image. They are a warty growth or spicule underneath the nail, as shown in the second image, due to subungual hyperkeratosis. In the first instance, it can be appropriate to monitor the lesion for any increase in size, change in shape, or change in uniformity, and if there is a high suspicion of malignancy, then you can consider a biopsy. Management can be either monitoring or nail excision at the time of biopsy, if indicated. Subungual exodosis. Subungual exodosis is a benign lesion arising from bony or cartilaginous tissue in the fingers or hands. It's more common in the toes, in particular the great toe, though can affect all of the digits. They can be idiopathic or associated with trauma or long-term infection. It's usually a slowly growing lesion with a firm nodule growing over weeks to months and can cause pain along the nail bed. It can also cause onycholysis of the nail plate. They are benign lesions, though require X-rays to confirm that it's arising from bone or cartilage tissue. Management is surgical, with orthopedics input, under local anaesthetic, administered under the finger. The tumour is removed and the underlying bone is scraped clean to prevent recurrence. In this slide, we will discuss malignant lesions. Malignant lesions can be Bowen's disease or intraepidermal SCC, and malignant melanoma, and how we can differentiate this between melanocytic nevi. Bowen's disease of the nail is also called intraepidermal SCC or SCC in situ. The in situ means that it's confined to the epidermis and has not spread beyond the area. These lesions will be derived from flat squamous cells in the epidermis that produce keratin. Risk factors for this include exposure to UV radiation, exposure to arsenic, exposure to ionizing radiation, for example in the form of exposure to CT and X-rays, HPV infection, and being on immune suppression medications, or being immune suppressed due to other diseases, and previous or concurrent SCCs or BCCs. Cutaneous lesions will present as irregular asymmetrical scaly plaques, which can be orange or red in colour, typically on sun-exposed sites on the nails. When the lesion is present beneath the nail plate, it can cause erythronychia, which is a red streak in the nail, and this can also lead to red nail plate destruction. An ulcerated nodule of the nail bed or persistent lateral onycholysis not responding to treatment can be investigated for an SCC and should raise suspicion for this condition. The images on the slide show Bowen's disease of the nail and periungual region, with nail plate destruction shown in the first images. It can be misdiagnosed as paronychia, onychomycosis, for example, so careful examination is required. This may require biopsy for a gold standard diagnosis. Management can differ, although there is usually surgical excision required at the time of biopsy. Metastasis and local invasion are both rare, although bone involvement can be seen and can cause pain. In this slide, we will discuss melanonychia. Melanonychia is the term used to describe brown or black discoloration of the nail, either in a diffuse pattern or as a longitudinal band. It can be both benign or malignant and requires close observation and a low threshold for further investigation as a result. Benign melanonychia is more prevalent in people with skin of colour, for example Fitzpatrick skin type 5 or 6. Benign melanonychia can also be associated with some genetic disorders, trauma to the nail, some medications including chemotherapy and antimalarial agents, nutritional deficiencies such as vitamin B12 or folate, some connective tissue diseases, some endocrine diseases such as Addison's, Cushing's and acromegaly, HIV, SLE, and nail infections. It can also be a physiological finding in some ethnicities and during pregnancy. Benign melanonychia occurs due to melanocytic hyperplasia or activation in the nail matrix, where there is not usually a melanin deposited into the nail plate. Melanocytic nevi and lentiginous are benign lesions and are fairly common. Benign lesions are regularly pigmented and do not show banding or disruption of the nail plate. However, in clinical practice, differentiating between benign and suspicious lesions can be difficult, and we will discuss the key components suggestive of malignant lesions in the next slide. The key to this is close examination and monitoring over time to ensure the lesion is not changing colour, changing shape, or changing borders. Here are some images of benign melanonychia. It can affect several nails. It is narrow and regular, and there is no disruption of the nail plate, and will not change over time. In this slide, we will discuss melanoma. Melanoma of the nail unit is rare. However, it's often misdiagnosed or diagnosed late, and has a poor prognosis in these cases, as it is diagnosed later. It can metastasize to nearby lymph nodes and organs, and we should have a low index of suspicion for specialist referral under the 2-week wait pathway in the UK. It is actually the most common type of melanoma in deeply pigmented skin. Up to 75% of cases of melanoma in dark skinned populations involve the nail unit. It is more common in 60 to 70-year-olds. 75 to 90% will affect the great toe or the thumbnail. The most common type subtype on biopsy is acral lentiginous, but also can be nodular desmoplastic. It is not thought to be related to sun exposure and occurs due to proliferation of the melanocytes in the nail matrix. Risk factors include trauma, as well as a personal and family history of malignant melanoma. Clinically, it will show as an enlarging irregular band associated with nail plate destruction and Hutchinson sign, which we will discuss on the next slide. Here are some images of melanoma. It's important to note, as on the bottom left and middle, that melanoma on the nail can be amelanotic and therefore not have the pigmentation as suggested previously. Here we can see the bands are irregular and there is nail plate destruction in the top two images. In the bottom right image we can see that it's not a regular band and is instead an irregular shape. Here we have Hutchinson sign. This is an indicator of a malignant process versus a benign process. Clinically, it will show that the pigmentation extends from the nail into the proximal nail fold. You can see this clinically on examination with the naked eye, and sometimes you may not be able to visualize it, and you might have micro-Hutchinson sign, when the same phenomenon is only visualized under dermoscopy. The image below shows pseudo-Hutchinson sign, which is when the pigmentation itself appears to the naked eye to be extending into the nail fold. However, under dermoscopy it's appreciable to only be visible due to the transparency of the cuticle. This can be very difficult to differentiate from Hutchinson sign, so will likely require specialist referral anyway. The key points about melanoma, diagnosis and management. On examination, the lesion will need to be closely examined with measurement and clinical photography of the colour, width and borders of the lesion. The pattern of melanonychia can differ between races. For example, in Caucasian patients, longitudinal pigmentation is much less common. It's important to examine for any sign of nail dystrophy, nail plate destruction, any sign of previous trauma, are there any visible lesions below the nail plate, and any surrounding skin changes. Unlike a benign lesion, a malignant lesion will change over time, which is a key part of diagnosis. The key clinical and dermoscopic findings suggestive of a malignant lesion are melanonychia with a narrow brown or black pigmentation along the length of the nail plate that will be isolated to one finger. Like a melanoma on another area of the skin, these changes also involve some of the ABCD rules. The borders will become irregular and blurred at the margins. Pigmentation becomes more irregular and granular over time, and the colour may be grey or black. There is an increase of size of over 3 mm, especially at the proximal end, and a pigmented band may take up over 2/3 of the nail plate. As discussed previously, we may be able to see Hutchinson's or micro-Hutchinson sign on dermoscopy, and there may be generalized nail dystrophy. There is an alternative ABCDE for subungual melanomas page on DermNet, which we won't discuss here, but you can use for further reading. Lesions may also cause ulceration or bleeding, and there may be onycholysis or warty-like changes visible underneath the nail plate. They can become painful if there's any nail bone involvement or any nail plate dystrophy. Again, it's important to note that the nail unit melanoma may also be hypo or amelanotic, which means it's colourless or very pale. So again, it's highly important to have a low index of suspicion for other changes, such as nail dystrophy, with no clear history of trauma to rule out malignancy. Dermoscopy is a useful tool in diagnosis. However, if any clinical suspicion, should be referred onwards for biopsy. On biopsy, the most common of cases is acral lentiginous, and on biopsy we'll always be able to tell us if there's any local invasion. It's possible for melanoma for the nail plate to metastasize to lymph nodes and distant organs. Management in all cases is surgical removal, either wide excision if in situ or digital amputation in other cases. Mohs micrographic surgery is also considered as a digit-sparing approach, but can only be done under very specialist supervision. As in all cases of cancer, an MDT approach is taken. In general, subungual or ungual melanoma has a poorer prognosis than cutaneous melanoma, as it is often misdiagnosed or diagnosed late. The main prognostic factor for metastasis is thickness of melanoma at primary excision. These are a few take-home messages to be aware of and to take home from today's lecture. Most clinical exams require assessment of the nails in their systems exam, and they can be a clue to many diseases, although can also be physiological. It is important to examine the colour, shape and texture of the nails from different angles, and to be mindful to comment on the number of nails affected, any partial or full changes, and any surrounding skin changes. Skin diseases like psoriasis, eczema and lichen planus often have impacts on the nails and can have prognostic indications. Systemic diseases and genetic conditions can also affect the nails. In the context of pigmentation changes in the nails, always have a low index of suspicion for referral to secondary care, as these cases have poor prognoses when diagnosed late or incorrectly.